I'm going to spend the next 10 minutes or so talking about how structural damage progression impacts our patients with axial spondyloarthritis. So here are my disclosures. So I want to go through this with a case. This is a patient called Miss A. She's 35 years old. She's had inflammatory back pain, and much like these patients present in early disease, they follow a flare pattern with their backs. The pain will come and the pain will go, unlike the mechanical spinal patients, which seem to have more persistent pain over time. She's now unemployed. She's a smoker. You can see her X-ray showing bilateral grade 3 sacroiliitis, and she gets a diagnosis of radiographic axial spondyloarthritis some 7 years after the symptoms started. These are patients we're seeing in clinic all the time, and patients will come and say they're frustrated, their mood is low, they have chronic sleep problems, and fatigue is a major issue. You can see that she has high CRP of 15, her disease activity is high with a BASDA of 7 and an ASTAS over 4, back pain score of 8, and quality of life poor with a score of 14. And this is an unusual. Miss A represents patients we see all the time, and the research literature also supports this. So when Carl Gaffney and I looked at this a few years ago and we published on it, there were 1,200 patients in this study, 800 with radiographic disease, 400 with non-radiographic disease. If you look at the cohort overall, you saw an 8.5-year delay in diagnosis. But when we took the more recent 5 years between 2009 and 2013, whilst we were diagnosing 50% more patients, the delay in diagnosis, or the mean delay in diagnosis at least, was worse at around 9.4 years. The median in this study for delay in diagnosis was 5 years. And this does impact on the patients, and we see this in this nice systematic literature review that was done a few years ago. And if we look at the delay in diagnosis for those who are over 10 years, 41% of these patients were unemployed compared to only 20% who had a delay in diagnosis less than 4 years. If we look at employability, a great number of patients, over 90% of patients, have their employability impacted. And for me, again, in clinical practice, I do believe that employment or unemployment is a window of opportunity, and if we intervene in the right patient at the right time, we can really prevent the natural progression and evolution of unemployment. So it's not just unemployment, there's also disability, and by that I mean physical function and mobility. And the systematic literature review shows a greater number of studies showing significant negative impact of a delay in diagnosis on physical function and BAS-ME. Coming back to our patient, then, Miss A, we can see that it impacts her daily life. We can see the cervical spine involvement on her radiographs, and she talks about difficulty in driving because she can't look over her shoulder. She has difficulty in getting dressed. Coming back to the disability side of things, her physical function is moderately impaired with a BAS-V of 5, and a BAS-ME is really, for me, quite significantly impaired at 5.6. Her FACIT score measuring fatigue, remember, FACIT is a score between 0 and 52, and the higher the score, the better your fatigue. Again, moderately impaired at 25. Dennis has shown you how the MSAS is scored, and she has an MSAS of 24 out of 72. Now, Dennis has touched on this as well, but for me in clinical practice, this is an issue. So we know that if we look at radiographic progression here from the OASIS cohort, the progression at the cohort level is quite linear. It's about 2 units over 2 years, of 1 unit per year, and we can see this over the 12-year time point. But as Dennis alluded to earlier, at the individual patient level, there's huge heterogeneity. We have some patients in the bottom right who show no progression. We have some patients who show linear progression, and I do worry about these patients because the rate of change is so slow the clinician and the patients can miss that radiographic progression over time, mainly because the patient can accommodate to it so well. But again, as Dennis said, the people on the left are probably our biggest worries. This rapid progression, huge progression happening quite quickly. And what we don't want to do is send these patients off for a year with an anti-inflammatory and come back, because again, we're going to miss that window of opportunity to intervene. So how might we identify these patients earlier? The research gives us some clues. Here, again, from the OASIS cohort, we see the men will progress more than women. HLA-B27 positive patients progress more than those who are negative. And if you have radiographic damage at baseline, again, you're much more likely to progress. Another very important parameter is CRP, relevant for Miss A, whose CRP was elevated at 15. And if you have a raised CRP, you have a 4-fold increase in radiographic progression. Now, Maxime Duguidos's study from back in, I think it was 1999 or 2000, showed that for AxSpA patients, only around 40% of patients have a raised CRP. So whilst it's not terribly helpful, when it is raised, I really take note of those patients because I think I probably should intervene if clinically appropriate. So I've talked about those parameters. We can, and Dennis showed you this as well, but we can start putting some of those parameters together with matrices such as this. This is now a decade old, but very relevant in clinical practice. What we see is if a patient has a raised CRP, if they're a smoker and they've baseline syndesmophytes, more than 50% of those patients will get a worsening of radiographic progression over 2 years. The story around disease activity is also highly relevant, and data here from the GESPIC cohort showing us that if we leave our patients in high disease activity, so an ASDAS of more than 3.5, the mean MSAS change was 1.73 units compared to those patients in low disease activity where the rate of change was only 0.59. Again, looking at this in a different way, of patients who have a more than 2-point progression over 2 years, the patients in high disease activity, 25% of those patients showing that worsening over 2 years compared to the low disease activity patients where only 13% of patients progressed. Now, understanding the relationship between structural damage, disease activity, function, and mobility is complex. We can see that if a patient has a lot of structural damage, it's quite obvious that they're going to have quite bad function and mobility impairment, but that relationship in earlier disease is much more difficult. This is data from the GESPIC cohort. These patients had under 5 years of disease. They had rather a low amount of radiographic damage. Most of them had an MSAS score of 24 or below. And what we saw is if you look at the comparison of the rate of change in the MSAS and BAS-Phi and the rate of change with MSAS and BAS-ME, there is a very weak relationship such that you need an increase of 20 MSAS points to be responsible for 1 increase in BAS-Phi point. And an increase of 12 MSAS points that would be responsible for an increase in 1 BAS-ME point. So patients can, at least in early disease, can accommodate quite a lot of radiographic change before they have an effect on function and mobility. And in fact, in this study, the strongest relationship was with disease activity, which makes sense then to target in our early disease patients. Coming back to Miss A, then, we saw that she's a smoker. She has a high CRP. Her disease activity was high. She has functional and mobility impairment, and she had 2 anti-inflammatories, and we decided to treat her with a biological DMARD. And for a patient with relatively established disease, these are the improvements I would expect to see. Her BASDA and BAS-Phi improve to a score of 4. With biological DMARDs, we don't see massive improvements in BAS-ME, particularly in patients who have BAS-ME scores at this level. For me, it's the combination of the biological DMARD and help from our physiotherapy colleagues. The combination of that is likely to achieve the greater improvement. We don't see an improvement in an MSAS score as shown. So I've talked about predictors of radiographic progression. What about predictors of response to biologic therapies? And I'm showing you results from this meta-analysis, which looked at BASDAI-50, the ASAS-20, ASAS-40, and BASDAI. And from this meta-analysis, we see that CRP was the best at predicting all of those outcomes, with B27 positivity coming in a close second. Younger age, male, gender, lower BAS-Phi, and higher BASDAI do also predict these, but only for the BASDAI-50. And again, coming back to this disease duration story, which I do think is important, we are going to have the best impact on our patients if we treat them in early disease. And this is shown by these 4 large clinical trials of etanercept 50 milligrams a week, where if you treat patients who've had disease for 10 years, only a fifth of them achieve partial remission, whereas if you treat patients earlier, 0 to 2 years of disease, just over a third will achieve partial remission. If we want to look at the BASDAI-50, and this nicely brings in the relationship with CRP and disease duration, we know that CRP will predict response to biologics, but if you treat these patients later on with 25 years of disease in blue, you see that the response or the chance of getting BASDAI-50 is not as good as if you treat them earlier on. And for me, when patients come in and say, I want to leave these drugs till I'm really bad, I want to try other things first, in the clinically relevant and appropriate patient, I have that discussion about let's get you on this treatment straight away because we're going to get the best clinical outcome and the best radiographic outcome for you. This is also shown in the measure studies, where if patients had more than 10 years of disease, you only saw ASTAS inactive disease, so that's an ASTAS less than 1.3 in 10% of patients, and it was double the number if they had less than 1 year of disease. If you look at the BASDAI-50 by the patients' age groups, again, it's the younger patients who are more likely to achieve a BASDAI-50. Just a couple of slides on psoriatic arthritis and looking at the relationship between disease activity and structural damage from the GO-REVEAL study. And here you're seeing disease activity with the DAPSA, and the higher the DAPSA, the greater functional impairment as measured by the HAC. If we look at the radiographic damage, an interesting story here between those who are in remission and those who are not. And you see that as the modified Sharp-Van der Heide score increases, you have greater functional impairment, but those who are in remission are not as badly affected. And corresponding data from the FUTURE-5 study with psoriatic arthritis showing patients who are in sustained DAPSA remission, and this was defined if they had the same response at least 2 out of the next 6 visits, which happened every 8 weeks. And what we see, the patients who are in sustained DAPSA remission have the greatest change in their physical function scores. Similarly, the patients who are in sustained DAPSA remission also show the greatest proportion of non-progression, and it is quite similar to those in DAPSA remission at 1 instance as well. So to summarize my talk, a delay in axial spondyloarthritis or psoriatic arthritis diagnosis, hopefully I've shown you, does severely impact our patients, resulting in poor mobility and function and increasing their chance of disease progression. If, sadly, there is that irreversible structural damage, this leaves the patients with axial SpA and PSA in constant pain, adversely affecting their physical function and quality of life. There are several patient characteristics and clinical factors that we potentially could use in routine clinical care to identify these patients who are at most risk of progression, identify the patients who are most likely to respond to the biological DMARD, and thereby prevent radiographic progression for them in the longer term. Achieving and sustaining low disease activity does improve outcomes for our patients with maintaining physical function and reducing structural damage progression. And I've shown you with Miss A, who's the patient of ours, experiencing a reduction in disease activity and improvement in function when she was treated with biological DMARDs, but really, I wish I'd met Miss A before and intervened at an earlier stage with a biological DMARD, because I would have been more likely to get remission for her and a better long-term outcome where radiographic damage is concerned. Thank you.